Excellent. Welcome back, everybody, and welcome back online. A reminder again to speak really slowly and clearly, please, so that we make sure that everybody's able to understand all the brilliant ideas being presented. So the next session is education in global health. And, so this is looking at good practice and innovative approaches in healthcare education so that we can equip people with knowledge, skills and competencies needed to build resilient health systems. So the speakers are going to consider the role of global health and health education and ongoing professional development, and asked also what impact global health education experience and exposure has on healthcare in the UK and across the world. So I'm really pleased that Dr. Elinor Moore is going to chair this session. Elinor is a consultant in infectious diseases at Cambridge University Hospitals. She's also training programme director for infectious diseases in the east of England. And as Isabel said earlier, she and Elinor and Isabel are associate deans for global health, running the Global Health Volunteering Programme for NHS England. So welcome, Elinor.
Thank you. Honestly, no need to clap. I haven't done anything. But I'm going to introduce our first speaker, who unfortunately was hoping to be here, but traffic, weather, etc. has meant that she's got stuck somewhere. But she's going to deliver her talk online for us. So this is Dr. Aneesa Ahmed. And she is head of programs and strategic partnerships for Amref. For those who don't know about Amref, I'm sure she's going to tell you all about it. It's a fabulous organisation. So we need to somehow find her. It's coming. It's coming.
Hi, Eleanor.
There she is.
Hi.
Hi, can you hear us?
I can, yeah.
Perfect.
Can everyone see?
Yes, we can hear you nice and clearly. Please do go ahead.
Perfect, thank you. So firstly, just to say, as Eleanor said, my apologies. I had really hoped to be there in person, but both car issues and a combination of public transport just was not on my side. So I've come back and I'm going to be presenting virtually now. So just wanted to check, is it easier for me to present my slides directly or something from there you can go?
Just say that again.
Would you like me to share my slides from my end, or is somebody in the...
Yes, I'm getting thumbs up all around. Yes, please.
Okay, perfect.
Okay, just move a little bit closer so that we can hear you well.
Yep, can you hear me now?
Yep. And then do share your slides.
I'm just going to pop up my... Hopefully, everyone can see this.
Yeah, we see three lovely ladies in pink.
Perfect, great. And can you hear me better now?
Yes, we can.
Perfect, great, thank you. So, as I mentioned, my name is Aneesa. I'm Head of Programs and Strategic Partnerships for Amref Health Africa UK. And today I'm going to be talking to you about the work that we do around educating health workers across the African continent and how that really translates into sort of performance and improved health outcomes. So essentially how we go from hospital to clinic and talking about some of the innovative solutions that we use. Before I go into that, I thought it would be quite nice just to give you a bit of an overview of who we are at Amref Health Africa. So we are an African-led organisation. We're headquartered in Nairobi in Kenya, and we have over 65 years of experience in central health systems. And our approach has been and is around supporting African communities to health ranges. So we firmly believe that, the communities that we work with and for can experience some of these challenges are also best placed to sort of determine the best solutions based on context and others. We partner in 35 countries across the continent, and we have quite a big presence. Some of that is physical offices, and some of that is in partner with local organisations on the ground. And we work with some of the most remote and vulnerable communities towards achieving our vision of long-lasting healthcare. And, part of that is the vision of when we think about addressing global health inequity, you can't do that without looking at some of the most marginalised and remote communities to ensure that nobody is left behind. So our vision of Mulwafu, how changed, how we're doing that, and what is our approach? We have two key kind of clinical platforms that we are prioritising. The first one is around catalysing and driving community-led and people-centred health systems. So this comes back to what I just said around how we strongly believe in community-led engagement, and we feel like that's such a key driver towards sustainable strengthening of health systems. And that encompasses lots of things, working with civil society, improving community health services, training health workers, and using innovation, both digital and non-digital. And of course, in my presentation, I'm going to be talking about the last two of those things,
Aneesa,
and the innovation.
Aneesa, can I just stop you a second?
Yeah.
I think people in the audience are struggling to hear. Is it? Yeah, just if you just go a little bit slower, it might just. Yeah. I think people will hear you better. Does she need to get nearer to the microphone? Bit near. Yeah, go a bit nearer and a bit slower, I think, because it's just slightly muffled for us.
That's fine. I'll try to speak a bit more loudly as well. Is that better?
Yes. Yeah. Yeah, I think if it goes slower, we'll be able to hear it properly, won't we? Yeah, people are nodding. Okay.
So the second platform that, just back to me if people can't hear again. So the second platform, so we talked about the community-led and people-centred health system, and the second platform that we are looking to address is all around social determinants of health. So what I mean by that is, when we talk about improving health outcomes, yes, there are lots of factors in the health system and in the health sector that we can sort of address to improve health outcomes, but actually long-lasting health change won't happen if we don't look at factors that sit outside of the health sector that also kind of affect your health outcomes. And what I mean by that is, we've seen a lot of this, particularly recently, but the links between climate change and health, things like education. We know that livelihoods have an impact on health outcomes, and we know that gender has an impact on health outcomes. So all of those sorts of things. And what Amref is doing is making sure that our programs are integrated wherever possible, so that we are improving health systems while also addressing the social determinants of health. That's a snapshot of who we are. What I'm going to very quickly touch upon, because I think everyone is probably very familiar with this, is why education and training the health workforce is so important. So the WHO minimum standard is 44.5 health workers per 10,000 people. Now, in the African region and in countries that we're nowhere near this amount, and actually the differences are quite vast, which is why I haven't given you an average across the continent, because I don't think it reflects the true needs in the region. But to give you a sense, in Zambia, which is one of the countries that is probably closest to the standard, there are about 33 health workers per 10,000 people. So Zambia is one of the countries that's kind of on the better end of that scale, but still not meeting that minimum standard. So that gives you a sense of why this is so important. And then, in the African region, we know that they bear a quarter of the global disease burden, but actually when you look at the reflection in terms of trained health workers, there's just over 1%. So there's a huge gap there that needs to be addressed. And then just to add on to that, some countries and regions are exacerbated by the rural and urban distribution. We know that people who live in rural and hard-to-reach communities generally have worse access to health services and health workers. So when you're looking at areas where there are high rural populations, that exacerbates this gap that we're seeing. And the reason this is a key focus for Amref is because across the African region, there is a predicted shortage of 6 million health workers by 2030, so in the next 5 years. And a third of those are expected to be community health workers. So these are health workers that generally work in some of those rural and hard-to-reach communities, and they're really the link between those communities and the health system. So that just gives you a bit of an indication as to why it's so important to address this. So what I'm going to touch on next before I go into a specific example is Amref South Africa's approach. So our approach is around ensuring the fit-for-purpose health workforce will improve skills and productivity. And what I mean by that is it's not just about, increasing the number of health workers, so reaching that 6 million. It's also about making sure that, that's sustainable, that they are equipped, that they are trained appropriately in the areas that they need to be trained in, that there is ongoing education and continuous professional development, so that they are truly a fit-for-purpose skilled health workforce. There are many ways that Amref is doing that. So, there's leadership management and governance, the key part of this. sustainable financing for remuneration, but also various financing models to address this. And a key part is training and capacity building, and that's what I'm going to be talking about today and give you an example of that. So Amref South Africa has been training health workers for decades. And actually the way and the approach that we use to train health workers has changed over time. So essentially it's evolved based on the tools of the time. So it started off very conventional face-to-face classroom training, something we're all familiar with. And as kind of technology evolved and became more fast-paced, it then moved to e-learning. So this is basically where, we had computer rooms set up in nursing institutes and things like that, and we had electronic courses that people would complete. And as schools evolved further, we then moved into mLearning, which is mobile platforms, and that is what I'm going to be talking about today. It's two of Amref's mobile training platforms that we use, and you'll hopefully get a sense of how and why we have these two different tools and what the benefits are and how we've tailored them based on what we know in the context that we work in. And to give you an indication of kind of how important it is to Amref, in the last year alone, in 2023, we supported 60,500 health workers with training through these approaches. So that hopefully gives you a bit of an introduction. And now what I'm going to do is just go into the mLearning tools that I mentioned. So Amref has two mobile platforms that we use to train health workers. One is called Leap and one is called Kamuzu. So Leap, I'll go into that first. It's essentially training that we do using a basic phone. So essentially this would be a phone that allows you to send text messages, make phone calls, but not much more beyond that. It doesn't have smart capabilities, it's not connected to Wi-Fi. And I'll go into sort of, in my next slide, a kind of image of how we use it. But the thing I was going to say is that because it's based on network connectivity rather than Wi-Fi, it's rolled out country-specific, so we work very closely with ministries of health and other relevant network providers in each country to roll this out. So it's currently rolled out in 8 countries, and the content is all Ministry of Health approved curriculum, and that's kind of the first platform we have. And the second one we have, Kamuzu, is probably something that I think people are more familiar with. And this is kind of your smartphone. So essentially you would download an app on your phone called Kamuzu. You'd have login details for that, and then you can access a range of online courses. And you can have videos, you can have graphics, it can be accessed anywhere, so you're not limited by having to be logged out in the country. And this content is all developed with universities, with regulatory bodies, and of course ministries of health. The thing I wanted to flag here is that what determines which tool we use is based on the context of the case. So if it's an area where we know a lot of health workers have smartphones and access to smartphones, we would go down the Kamuzu route. If it's an area, so sometimes in particular rural areas where Wi-Fi connectivity is poor, or people generally tend to have more basic phones, we would go down the route of developing modules on Leap. And so generally what we have seen, although this may change moving forward, is that community health workers, so people who work in some of those rural and hard-to-reach areas, generally use Leap, whereas our healthcare professionals, the health facility-based workers, generally have courses on Kamuzu. So that's an introduction to our mLearning tool. Now what I'm just going to do, just to bring it to life a little bit, is to just show you a snapshot of how this works. So in Leap, you'll see that there's a phone there, they've sent a message saying, the first topic you will learn about is family planning. There's a series of text messages and voicemails where, messages and information is shared, but there's also interaction. So here in this green box, you can see that, whichever health worker is doing this, they receive this assignment that they have to do. And essentially it's testing their learning and their knowledge and making sure that's being put into practice. So they're being asked to visit 3 households, discuss family planning, identifying myths and misconceptions, all of the things that would have been covered in this module. And then they would then report back on that, so they would send a voicemail reporting back on the assignment and the 3 households that they're visiting. So that's kind of how we work. And then Kamuzu, I'm not going to go into this in too much detail, I think this is one that's more familiar to this. You can just see that this is an example of a pneumonia module. So there's an app, you click on the app, you click on Let's Get Started, then you go through the various sort of modules that they have in there. If you use images, sometimes there are videos to help explain things, and you basically do tests along the way to pass that module. So that's something that we're more familiar with. And what I want to do here is just pause, and I want to talk about why mobile tools are so important. So from the health worker perspective, and I talked about, the workforce shortage that already exists and is looking to worsen if we don't address it over the coming years. In a scenario like that, mobile platforms give users the flexibility to learn in their own time. They're not taken away from their places of work for periods at a time to complete courses. They can do it flexibly around work, around family commitments, all of these things, but it's still contributing to their development. And it's really important for two reasons. One is, of course, it doesn't then, working like likelihood, not losing income, which, as I mentioned, is one of those social determinants of health that can affect people's health outcomes. But also, secondly, it means that, if you're taking health workers away from a situation where there's already a shortage, you're exacerbating that shortage. So this is a way to kind of still support skilled health workforce without exacerbating the shortage that already exists. The other way that it's been really valuable, and we really saw this during the COVID pandemic, when there were restrictions on movement and social distancing and things like that, is that it allowed us to still share COVID-19 messaging with health workers, and particularly those community health workers who work in some of those rural areas. It allows us to remotely share messages and for them to improve their knowledge and awareness on COVID-19 and share that with communities around prevention and things like that, which in a situation like COVID was a huge, huge benefit. And we can see how it can continue to be a huge benefit. So if you think about, things like climate change and we've seen the floods that have been happening in Kenya and Pakistan, floods can result in communities being isolated, washed away roads, they're kind of stuck in a certain situation. And again, in those situations, you can share with community health workers messages around whether it's cholera outbreaks, malaria outbreaks, to help them be aware and pass that information on to communities for prevention and safe distancing. So I just wanted to stop there to talk about why this is so important. And there's a quick case study here. I won't go into this in too much detail, but it's literally just to give you an example to kind of put a face to some of this that we do. It's a nurse in Zambia, and it was around sort of how to use GBU to upskill to a diploma level, which was the required level for Community Health in Zambia was targeted. From the health nurse's perspective, she was saying that, it's helping her achieve her goals, but she was also wanting to qualify and wanting to continue developing. And this allowed her to do that in her own time and in a way that suited her. The last thing I'm going to go into very quickly is that's all well and good. So I've talked about training health workers and, we've proved knowledge and, when we ask health workers to do assignments or to complete tests, great, there's an improvement in knowledge. One of the things that we were struggling with was getting a sense of those courses and whether they translate to improved performance. So it's all well and good saying, there's this knowledge gain in this disease area, but is that translating to the health outcomes that we want to see or we should be seeing? And this was a gap that we kind of identified. And over the past couple of years, we worked with, so GSK is a long-standing partner of Amref, and Cognizant is a digital tech company. And what we did is we worked with both organisations to try and find a way to have a solution around this. And essentially what we did is came up with the development of various dashboards. So this was in collaboration and conversation with people who are using these tools. So health workers, tutors, government, to make sure that the data and the dashboards that were being designed were based on what they needed. So I've given you just two snapshots. I apologise for the poor quality of the images, but you can see there is the tutor dashboard. So that's very much around tutors saying that they wanted to get a sense of the health workers and students they're supporting. What is the progress that's being made? Are there any challenges? Is there an area that everybody's getting stuck in so that they know how to best support them? And also to identify, is there an issue with the module itself? If everyone's getting stuck in the same content or the same area, do we need to go back and re-look at the content and how the module is being delivered? That's one. And the second one is this work about linking it to training performance. So before we have the tools and we have health workers that's trained. That same health worker also has another Amref tool that I do not have time to go into, where they are essentially submitting data around cases and things that they're referring in the community. However, the two weren't speaking to each other. So we were getting data about health worker knowledge, and we were getting data about, number of referrals hospital cases identified, but we had no way of knowing if that was linked to, is it because we've changed the health worker list that we're now getting an increasing number of referrals? So what you see on sort of your right-hand side is the linkage there. So you're seeing that, one health worker, we can look at their training performance and then link that to, is this resulting in an increased number of referrals? And if it is fantastic, we can see that the training is linked to performance. And if it's not, then we go back to the drawing board and we try to understand why that is the case, and we try to make decisions either if the training supply or further support is needed to translate that knowledge into practice, we can break it down. But it gives us the data that we didn't have before. And then I just wanted to end with saying, at the beginning I talked about the importance of community-owned and led. So this solution was very much developed alongside the key stakeholders who are using this. And it's reflected in kind of the feedback that we got when we tried to validate the solution. So, the users then met their requirements. They talked about how critical it was and that they would recommend it to other colleagues as well. And it's now been rolled out in 3 countries. It's been rolled out in Kenya, Zambia and Senegal, and we're looking to roll it out in other countries as our programmes are implemented. And I will stop there, and I'm hoping that you heard me from this presentation.
Thank you so much. Thank you, Aneesa. You've got a lovely round of applause, so I think people heard you. Thank you so much. But just stay put, because we'll come back to you with questions at the end when the others have spoken. So we'll move on to Professor Wakisa Mulwafu, who is the Dean of the School of Medicine and Oral Health in Blantyre in Malawi. He has a pre-recorded lecture, and Isabel, you're going to be the face-to-face person here, I believe, if there are any questions that come up from his pre-recording. So, is that him? Again? Here you go.
Thank you for having me. Here at the university, what was the University of Malawi, now the Kamuzu University of Health Sciences, became Kamuzu University of Health Sciences 3 years ago, having the medical school, formerly known as the College of Medicine and Kamuzu College of Nursing, joined together to form one university. And now we're 3 years old, but as a medical school, we've been training doctors since 1992, when our first graduates came out of this medical school. The first group there were only 12 students who graduated at that time. And the numbers obviously have been growing, but not at a rate that would desire. So at the moment, we're graduating about 60 to 70 medical doctors a year. And so since 1992 up to now, we've graduated about 1,500 doctors. This is for the whole of Malawi. And this is the only medical school that's training doctors. So if you just look at the numbers now, if you look at 1,500, and maybe if we take out some of the people that have gone outside the country, they're not working in Malawi, we're probably looking at about 1,000 medical doctors in the country against a population of 19 million Malawians. So we're talking of a ratio of doctor-patient ratio of 0.53 per 1,000 population. If you compare that to the doctor-patient ratio in the UK, it is 3.18, I believe. And so we are way, way below average of doctor-patient ratio. It's the same thing if you look at the other cadres, healthcare workers, you find that the ratios are quite low. I mean, if you look at the nurses, you look at the pharmacists, physiotherapists, medical laboratory scientists, the ratios are also quite low in terms of serving the population of Malawi. So why, you might ask, why is this the case? There are many reasons, I think, why we've got low ratios. One, the numbers that we, recruiting into the medical school are quite low because we are limited by the infrastructure. The infrastructure is not enough to accommodate all the students that would love to recruit into the medical school. The other challenge that we have, obviously, it's quite expensive to train medical doctors. So we're using the hospitals, the Ministry of Health hospitals, to train our medical doctors. And most of these hospitals, they don't have enough staff members, enough doctors to train the medical doctors. It's something that I think we can work on quite easily if we increased the output of the portfolio, if we increase the number of medical doctors that are graduating from this medical school. It's a simple correlation. The more you graduate from the medical school, the more people end up specializing, and the more people end up working in the central hospitals. So that's something that I think can be worked on easily as long as we increase the output from the medical school. The other area that we're working on is improving the research output of the doctors, especially the clinicians, because you know the clinicians are quite busy. They like to be on the bedside. So we're introducing the PhD programs that will make sure that the doctors, they still spend some time at the bedside, but at the same time, they're working on some research outputs. Because we believe that if they can improve their research capacity, their bedside capacity will also improve. So at the moment, we're just working on the curriculum, which we hope will be approved soon by our university. And once that has been approved, we should be able to start recruiting doctors to go into this program. Looking to the future in terms of how we want to increase, especially if you may allow me just to talk about the medical doctors. We're recruiting at the moment, about 100 medical students a year. And this is, like I said, the only medical school in the country. If you look at our neighbor, Zambia, they've got many medical schools now. Now they're recruiting about 2,000 medical students a year. Kenya is the same thing. Ethiopia is the same thing. So as a country, we're lagging behind. Even within the region, we're lagging behind in terms of recruitment of students going into the medical school. Like I said, to me, as far as I'm concerned, the major issue is infrastructure. I think that's where we need to start, because we don't have enough teaching spaces, enough spaces for the lab. Obviously, coming up with the infrastructure and building this kind of infrastructure will cost money. We have our plans in place, and what we're looking for is the resources, the finances in order to build the infrastructure so that we can increase the number of medical doctors in this country. We've also been challenged by the Ministry of Health, our Ministry of Health here, and they've said that for us just to meet the minimum, what we call the health benefits package, this is like the small universal healthcare package that is accessible to the patients out there in the district hospitals. They said that we need to increase the number of students that we recruit by 1,000%. But they haven't actually provided the resources, but they've just made that estimate. But we know that, again, the bottleneck, I keep saying, is the infrastructure. And once we have the funds to build the infrastructure, increase the teaching spaces, then we'll be able to increase the numbers. We might not increase it to 1,000%, but maybe 200, 300%. And I think that will still be quite an achievement.